Welcome to the Next Orbit podcast, where connecting healthcare's data is the next frontier. We take you inside conversations with policymakers, healthcare leaders, disruptors, and visionaries who are pushing boundaries in a system that resists change. This is your launchpad. Here is your host, Ben Wade.
Our guest today has been nationally recognized by Becker's as a top CMO to know 3 years in a row. He's the author of the Chief Medical Officer's Essential Guidebook, and his work consistently focuses on driving measurable improvements in quality, in safety, and in patient experience while advancing physician engagement and organizational culture. Dr. Mark Olszyk, welcome, and thank you for joining us today.
Well, thank you very much, Ben. It's a pleasure to be here.
Today, we'll be discussing ethical use of AI in healthcare settings. It's a subject we've touched on before and one that we'll continue to explore. But for today, I'd like to ground our conversation on AI in the classic Beauchamp and Childress principles of biomedical ethics. We'll explore what trustworthy AI actually means using the lens of history and data integrity. And we'll discuss practical risk of deployment and the impact on the physician-patient relationship. So to start, Dr. Olszyk, if you're familiar, can you share what the four core principles of Beauchamp and Childress biomedical ethics are?
Sure. I'll go through that, but might help to take a step back and see where it came from. So Beauchamp and Childress were philosophers, and their approach to medical ethics arose from the Belmont Report in the early 1970s. So when we speak about ethics, and ethics is a way to guide our actions, there's three normative approaches, three norms we often try to frame the conversations in. So we approach an ethical dilemma, which avenue do we choose to pursue when we're confronted with a dilemma? We can use the oldest and probably the most intuitive approach, and that's virtue ethics, which is nothing more than, what would somebody I admire do? What would Jesus do? What would the Buddha do? What would my grandfather do? What would my mentor from medical school or residency recommend, and something like that? And I think this is the one that's most available to us on a daily basis. We try to base our behaviors and our approach on somebody that we've learned from, someone we've admired. Certainly in medicine, where we go through a very long apprenticeship, we have lots of role models, and we might think back to what one of our mentors would have told us. So that's virtue ethics. That doesn't really help out in more sophisticated dilemmas. So Immanuel Kant, the diminutive 18th century German philosopher, came up with deontology, which is essentially the golden rule. So we're going to apply an ethic, we're going to apply a norm, and it's going to attain to all people in all cases that we confront in such a situation. So I'm going to pass a law, and everyone is going to be subject to it. There's no special carve-outs or exceptions. So if we say that there's certain eligibility criteria for a vaccine or for a procedure or waiting for an organ transplant, we're going to apply that, with the blindfold of justice. Everyone is going to be affected equally. Then later on, John Stuart Mill, Jeremy Bentham came up with utilitarianism, and that's trying to do the most good for the greatest amount of people. So you say that, you recognize someone might not benefit, but we're going to try to do the best for the most people, which sounds pretty good until you get right down to it. So there's a famous philosophical puzzle, the trolley problem, and it posits, you're at the switch, the control switch of a railroad bed, and there's a trolley coming down the hill, and it's barreling toward these five people who are tied to the track. Well, you can elect to throw the switch and send it off in a different direction, where it's going to run over one person. Now, you'll be responsible for the demise of that one person, but you're going to save five. So that's utilitarianism. We're going to do the greatest good for the greatest number of people. Makes sense. Until you face the possibility that one person might be your spouse, be your child, maybe be yourself, or you can abstract that and say, well, okay, we're going to save 5 lives. 5 people need organs, 2 kidneys, a liver, a heart. Well, there's a perfectly healthy person, and if we go after them and take out their organs, well, yeah, we're gonna lose one person, but we're gonna save 5. Well, so this is what Beauchamp and Childress were trying to resolve. So they came up with principlism, not some pie in the sky, overarching normative philosophy, but what do we actually do, especially in medical ethics? So they came up with 4 pillars. One is autonomy, and that's letting patients make their own decisions. They're going to have agency over their own healthcare, over their own outcomes. They're going to participate in the decision making. Beneficence, and that's promoting the patient's good. That sounds great. Non-maleficence, and that just is do no harm. First do no harm. It's a very old principle in medicine. And then finally, justice, and that's making sure everyone is treated equally, without bias, without favor. So autonomy, beneficence, non-malfeasance, and justice. And if you confront the trolley problem, you're going to have to ask that one person, is it okay if we run you over? We're probably going to say no, but that helps divest some of the responsibility, from one person acting as the sole agent to everybody. So including the patient, the family, the community, the society. So that's embracing more people in the decision making. I think that's what Beauchamp and Childress were trying to reach toward.
Dr. Olszyk, those are great principles. Those are things that make a lot of sense. And actually, I'm more comfortable with that than the idea of somebody flipping a switch on me and running me over for the benefit of 5 people, which I'm guessing, as you said, most people would feel that way. The trick that we have to deal with right now, as you're probably aware, is with these new models in generative AI that are helping inform a lot of decisions and a lot of work that are being done. They are not always, they're opaque sometimes. In fact, they're often opaque because of the way that they work. And so it seems to me that we need, perhaps a 5th principle there. And I'm wondering about your take on that. I mean, for example, what I worry about when I'm thinking about these things is, hallucinations. Everybody's heard about hallucinations. You want to make sure that doesn't affect care. But more importantly, and this is a question I've been thinking about generally when it comes to AI and things working autonomously. If we start to remove people from the equation, what happens? Who's ultimately accountable for the decisions that are made? And if something goes poorly, for a patient or in some scenario, how do we deal with that ethically? And so I'd love to get your thoughts on that, or your take on kind of what you see emerging, or what's needed here to fill that gap.
Well, I think it's always helpful to ground ourselves in the principles that have guided us this far, because we're familiar with them. So we can take the 4 principles from Beauchamp and Childress. Autonomy. So we want to disclose to the patients that we're using it. One application we've been using in the past year or so is ambient AI, which is nothing more than having a agentic AI scribe in the room. And patients are amazingly fine with that. I think no one has a real problem with using a virtual dictaphone, especially because it liberates the provider, so they're not constantly tapping into their keyboard. So that's something where it's actually allowing or promoting for a human connection. So we definitely disclose in that case. I don't know that we have good standards to disclose in every single case where it enters the healthcare decision-making equation. We can talk more about that. Beneficence, obviously, we want to do things that are going to benefit the patient. And we have to reevaluate the tools and retire them as needed to make sure we're doing the most good for every patient. non-maleficence. So now we're getting to it. So we want to have guardrails. We want to require strong evidence. We want to make sure that what we're doing actually has been effective and is helping. Justice, I think that's where it really, we really have seen a lot of concerns like the ones you raised. So far, and there's an article in, let me see, I have to look this up, but in STAT, there's an article by Mani Baranji, and she was quoting Goodman and Morgan in the New England Journal of Medicine group, and said that AI generates summaries, but 26% of them omit something, and we're not preserving the raw data. So yeah, it's vacuuming the conversations and it's reassembling them, which is great, and no one objects to that. But when you actually look at it, it might be leaving out a lot of nuance, and then it'll build. The predictive AI will say, hey, based on what I've heard and all the inputs and the conversations, these labs are suggested. This course of action is recommended, and then it just compounds itself. There's another article in PLOS, P-O-L-S, April 25 from the National Library of Medicine. It says that some of these AI models can exacerbate non-representative data sets. So until now, the application has been for pathology, radiology, imaging specialties. And really, I think the first application I heard of in widespread use, at least I saw it up close and personal, was in radiology, and it kind of pre-read images for the radiologists. Now these decision trees, algorithms, programs were based on loads and loads of structured data with real engineering. And now we're letting the models teach themselves on unstructured data. So we're not really sure that all the inputs are necessarily going in there. And it can be using, representatives of majority groups. So it might not be taking into account certain populations of people, maybe the underprivileged or minorities or people who are, less well represented. And it can compound those, inequalities. So we have to make sure that we're including into the data sets everybody's information so that it's evaluated equally. So we don't want to run into the situation where we had in the Tuskegee syphilis experiments or with Henrietta Lacks. We can talk more about that. So the fifth element, and we can get back to those, is governance and accountability. So we do in my hospital system, we have an AI governance committee, but we're largely looking at that from the lens of purchasing applications or programs or integrating something with the current EMR. It is not extended to what we allow the individual credentialed providers to do. And I have a friend, Lee Scheinbart, he has his own podcast, The Fire Chief. He raised that a few weeks ago. He said, hey, as far as I know, and I sit on the credentialing committee, I know in my instance, we're not, credentialing people, privileging providers to use open evidence or ChatGPT or any of the applications. We're looking at larger enterprise models, but not what individuals are using. Now, if someone wants to get privileged for a new procedure, say they haven't done arterial punctures before and they want to do that, or central lines, or if a surgeon wants to do a new technique, we actually put them through a pretty rigorous screening process, make sure that they have the proper education. We monitor them on a focused evaluation for a set amount of time. We had a breast surgeon a number of years ago. She wanted to use radioactive seeds to localize tumors. We had no one in the area doing that. We sent her off to a different state, really close monitoring, really close follow-up. We're not really doing that for things that are helping us make decisions. And I don't think anyone really knows what the data sets are behind these decision-making applications. And, we're certainly not licensing them or otherwise sanctioning them to be used in the hospital. Now, if we get a new scope, if we get a new surgical piece of equipment, we're going to look. We're going to meet with the manufacturer. We're going to have them meet with biomedical engineering. We're not doing that. So right now I don't think we have governance. That the umbrella of governance is not extending to what people are actually using on their own for decision making. I'm not even sure that's been fully thought out or covered. Now, if we're going to bring something in and plug it into the EMR, such as a decision-making tool or something that's going to predict which patient in the ED likely has sepsis and get to that patient first, that we're going to clearly vet and we're going to screen and we're going to make sure if we're plugging it into our own. But if you're walking around with your own handheld application, we're not really on top of that. Anybody can do that, and I don't know. Should we move to something where we tell all the providers in the hospital, hey, we want to know what you're using to make your medical decisions. So I think it's just early days right now. So we should have some governance and some accountability. And I think this is one of the first conversations I'm actually having on that topic.
Yeah, that's interesting. I think the idea of overcoming the black box nature, particularly, so I'd even apply it to what you're saying, because from a governance perspective, what your providers might be using personally would be kind of a black box at the governance level. And then when you look within, particularly with the generative AI and the way that they're trained and how they are training to some extent. Some of the interesting things that I'll just throw out there that I've been reviewing is, I was just looking last night and reading up on some research that's been done where they've been able to essentially show that you can take an AI that is a generative AI that's been trained on data and been, post-training to ensure that it's going to behave in an ethical way and it's not going to have any sort of biases. And then you can reintroduce those biases in a really indirect way because we still don't understand how they learn. In one case, they literally just transferred a bunch of numbers, a pattern of numbers into its training set, and boom, it started to behave weirdly and behave like what they considered the evil AI. They were trying to see can you easily train it out and keep it out, and so they were calling it evil AI. But it was interesting to me because I think, to your point about us being at the early stages, it's important that we do get some transparency into how these things work, particularly when it comes to things that are life and death decisions. And as you know, in healthcare, if I come in and say something gets omitted, as you were talking about, and then I make a decision, and then perhaps something happens, you can get into a state where things cascade. This is sort of just a systems problem, and humans are very complex systems. That sometimes a small decision and another bad small decision and another bad small decision accumulates into a catastrophe. And so, understanding that, for lack of a better word, kind of progression and the very beginning of it is critical to being able to avoid those things in the future. And if that began with decisions about which AI to use and how to use it, like from a governance perspective, and then deeper still, if it begins with how is this model trained, what data is used, how does it actually come to these decisions that it's providing, all of those seem pretty critical to me from a avoiding harm and ensuring autonomy and accountability perspective. And so I really appreciate what you're saying, I guess, on that. And I'm wondering, as you look at sort of historical patterns, you mentioned Henrietta Lacks, for example, or the Tuskegee. Clearly, those were probably based, I would guess, in the minds of those people who did that on this idea of doing the most good for the most people, and also obviously not valuing certain people at the same level as other people. So looking at some people as less than. How do you kind of, as you look forward, how do you think those things should apply to what we're doing now? And and what can we learn from those experiences as we're dealing with these new opportunities, but also these new risks related to AI in healthcare.
Yeah. So you're touching on the mirror side of the consideration using AI. It's not just what it's suggesting we do, using physicians as the agent, but what are we taking away from the patients that belongs to them? So one of the, as you were speaking, I ran across a word doing some reading prior to our conversation today. I'm going to try to get it all out without bumbling it, but algorithmovigilance. So vigilance over algorithms. I think there was a previous term, pharmacovigilance, making sure that we use medications correctly, don't overprescribe. We talk a lot about antibiotic stewardship. So I think we can apply that to using the algorithms as well. So algorithmovigilance. I think that would probably take up all the Scrabble letters on your board. But so I'm glad you mentioned. So Henrietta Lacks was an African American woman, actually not very far from here in Baltimore, back in the I think it was the early '50s, and she had a tumor. I think it was cervical. And anyway, her cells, were used to study, and under the right conditions, the researchers found that these cells were in fact immortal. They would just keep regenerating, and so it became the basis for a lot of research. In fact, I think her cell line, the HeLa, HeLa, HeLa cell line, is still being used, and obviously using it through research to come up with new medications, new cures, generated a lot of profit for different enterprises. But she was never even told that her cells were being used. She never received any compensation, during her lifetime. Likewise, the Tuskegee syphilis experiment was done over 4 decades by the government, public health service, on about 400 or so sharecroppers in Tuskegee. So they had syphilis. There was a treatment for it that was known about, penicillin, but they used them as a control group just to see what would happen over decades if they were left untreated. They weren't told that, hey, you have an option to get cured, and about 100 of them died. I'm not sure how many others suffered other consequences and sequela, but we need to tell the patients when we're using them or even using their data. So yeah, using a cell line, everyone now would say, of course, we got to, if we're taking your DNA, your cells, little pieces of you, and we're going to use those, and we're going to use those to our, not only benefit mankind, but maybe we'll get a little benefit monetarily of our own. Boy, you'd be upset if someone was going to do that and not tell you, or not include you, or not give you some sort of royalties, or give you the chance to donate them. But now with digital data, we can take your entire DNA code. We can take all of your biometrics, take all of your laboratories, and abstract those. And that's what's being used right now, right? All of our data is being used for these large, I'm not sure if it's a large language model, a large medical data model. You see a million things a million images. This is normal. This is normal. This is normal. This one is not normal. Even all those normals, those images, those are us. They belong to us. That's bodily autonomy. Are we all being informed that, we're being used? Now, I know in medical school residency, if somebody put up an X-ray, used as an example, either we hid the patient's name, or we would attribute it. But now we would even ask for permission. Hey, can I use this slide or discuss your case as a teaching example? Well, I don't know that we're really asking people. I'm not even sure we're the ones to be asking for their permission. I guess we're all maybe so used to it. We know that big search companies use our search histories, and they use that to market certain products to us. So maybe we've become, numb to it, that, someone's always surveilling us, and they can see our travel histories and who we associate with and who we call and where we go and what we buy. So, you know, it's a small step to just go ahead, use my health data. If that helps, advanced medical science, that's great. But we should probably think about that. Are we owed something? Does someone feel obligated, or should someone be obligated to share, the benefits with us for using our data, which really, you can argue is really us, and we should have autonomy and agency over that. So I don't know. I don't think that I've ever disclosed to a patient that, hey, I'm putting your information into an EMR, and maybe someone is going to abstract that and improve the system, or improve uh, predictive analysis. I mean, that's great, but we should probably think about having those conversations.
Based on what you said there, I've read a lot of articles about patients who are feeding LLMs, large language models, their own data. And do you think those patients are informed enough on what they're doing to do that? I mean, we want to give them the option to use their own data how they want, but I've also got concerns that they've reached the end of a long road. They have nowhere else to go, and they feel like, oh, if I just feed this into an LLM, maybe I can find the answer I've been looking for. But doing so out of desperation and not really thinking down the line of how that data might be used for financial gain, or even for training the models in a way that might be better for the greater good. But I just don't think that we're there yet to feed in patient data and train the models to arrive at the right conclusion every time.
Well, if I could kind of jump in for a minute and just make it a little bit more complicated, I think the reality is, like, I've worked in IT for a long time, and the reality is that we've got this ethos coming out of particularly Silicon Valley, which is like, move fast and break things, and the idea behind that is you learn by doing, and so if you sit around trying to get things perfect, you're not gonna achieve. It's become, I'm gonna say, from my personal perspective, a bit weaponized for business purposes, to say, well, also, maybe that means rather than waiting for laws and regulations and other things to catch up with us, we should just, break through those walls and deliver the value that we believe we can deliver. And that is, I guess I'd say it's almost in direct opposition to the, first do no harm principle behind medicine. And so as these two things come together, I think there is a lot of negotiation, and um, I'm going to assume in the end there's going to be a lot of regulation and law and things that have to be worked out. I hate to say it that way. For some people, will be disturbed to hear that, and I know that some of our, our entrepreneurial people in IT want to avoid being tied up too much until we learn where the value is and how to deliver that value. But the flip side is sometimes that break things um, can be pretty terrible. I mean, again, going back to the examples we just talked about, you, and if you want to move it into the physical world in engineering, you don't want to learn to build bridges by making bridges that seem great because they're light and flexible, but then in a windstorm they break apart and everybody falls into the river. That's it's moving fast, it's breaking things, it's learning, but it's too deadly. The cost is too high, and we don't want to do that. That's why we are in some areas more cautious. And I think anywhere where life is involved, and a person's autonomy and ability to deliver on, not even deliver, develop their own capabilities and be able to provide, contribute to society, but also enjoy a life that they believe is worth living. Um, that becomes pretty critical when we're talking about these kinds of things. So sorry to mess it up a little bit more, but I just think there are two almost like trains philosophically, like coming head to head here as we do this.
Right, right. Wow, that's a lot to unpack. That's like five separate discourses, right? As for No, that's cool. As for patients using their own data, I did it. I had my annual physical a couple of weeks ago. I took all my labs, and I got one of those body analysis scales, and I put in my lean cell mass and my body fat and my height, my weight, my activity levels. Fed into my stats from Strava. We all have wearables, trackables. I put it as much as possible, and I said, tell me what you think. And it was all good, but it did have some little nuances that which landed, and I wasn't overly alarmed. Like one of the my labs, my hematocrit was a little bit high. I think I was dehydrated that day, but it did say, hey, if it's a little high, based on your age, whatever, you might want to get a sleep study. Look for sleep apnea. Well, that's kind of helpful. It's something to think about. It can kind of guide your decisions. I also used an LLM to suggest an exercise program. Given my age and my condition, go to the gym every day. But what would you suggest to increase muscle flexibility, all that sort of stuff? Taking into account Peter Attia's goals for strength, being able to do an arm hang for 2 minutes and carry your own body weight, and etc. So it can help guide, but I think you have to have a good grounding and understand that. Now, someone could freak out and say, "Oh my God, I have sleep apnea. Look, I better go right out and get a CPAP machine." No, you have to have the experience to be able to temper all of that. And the patient segment that's probably the most vulnerable would be the mental health patients. And there was a study that came out of Brown, I think just recently. It's about to be published, maybe. It said that a lot of people are now relying on chatbots because why not? You think they maintain privacy. There's a low barrier to engage. You can do it right from your bedroom and say, hey, chatbot, let me spill my guts to you. And actually, the chatbot can be very encouraging and say, oh, well, tell me more. You're doing great. And they did an analysis, and it actually violated several ethical standards. If you were to say, let's compare it to a licensed therapist, it made a lot of suggestions. And I think we've heard of a case or two where someone may have taken their own life. And they were recently, speaking with the chatbot. I don't know if we can prove causality, but there is a concern that people who are the most vulnerable, maybe people who can't afford to go see a professional, and we might see more of that given the recent changes in health insurance. We might have more and more people turning to the bots. We've joked about having patients consult Dr. Google for 15, 20 years now. And sometimes, that can be a little annoying. People say, I've done my own research and this is, what I think and this is what I want. Like, not a whole lot of people, but some, and in some instances, it probably is beneficial. We don't spend, because of the way medicine is structured right now, a whole lot of time talking about lifestyle or talking about diet or talking about exercise. And if you can find an adjunct to help you out, something that can help, track you and look at your progression, that's great. As for, who is guiding the overall ethics of the application of AI, well, I think you identified it. There are people who are making money. I mean, you look at the stock market in the last year or so, and it's driven largely by, I don't know if it's speculation, if it's future, hope of returns on AI. I mean, Nvidia, is the one that always comes to mind. And I'm not a financial expert by any means, but there was the NeurIPS conference. I think it was in San Diego. It's written up in the Atlantic this month, the Atlantic Monthly, and say, hey, there's a lot of young 20-year-olds who are out there looking for jobs, and they want a compensation of 7 figures plus. So there's a lot of young, hungry people in their early adulthood, and there's a lot of big companies and big shareholders who see a lot to be gained from employing this. And we you don't you just read the newspapers and you see the federal government has adopted a policy where it told the states we don't want any regulation. So we have a large gap, large chasm to cover to employing any regulations. I was on the board of physicians for Maryland for 11 years. We haven't even really entered that space. So there's a lot of ground and to cover, and it keeps getting larger and harder to. I mean, just doing research, as you know, for this conversation today, it's hard to know where to start. I did see, happily, there's a lot of organizations out there that do want to, proceed, carefully, and to employ ethics and keep a human in the loop. All of the usual players, the CDC, World Health Organization, the AMA. One of them, let's see, there's one, CHAI, CHAI. I think that's the Center for Health AI, and they have a scorecard. If you go to their website, CHAI, Coalition for Health AI, look at the top banner, look under our work, the applied model card, and it talks about usefulness and safety and function. And you can actually, kind of keep yourself honest and say, what are my goals and how am I doing, and plug this all in, and it'll help guide you. So there are organizations out there who do want to be careful and respect, the pillars of principlism, of autonomy, beneficence, non-maleficence, justice, and even governance right now. So I think we have to join those organizations or listen to what they have to say and consider all of this, because the development keeps accelerating. There's a very low barrier for patients to engage. Healthcare providers need to be cognizant of what their patients are doing and how to advise them, and how to do no harm and advise everyone else to do no harm for themselves.
That's an interesting kind of avenue that I'd like to explore for a minute. So, like you, I've done similar things. I don't think I've plugged in all my, mostly because I was a little too nervous to plug in all my details. But I have as a man of a certain age who also is like, I need to maintain my health. I've said, what do you advise? Here's what you shared things about it, about who I
Mike,
am.
he also has the advantage of being a medical doctor too.
That's
So
true. That's true. So he knows what to share there. But having done that, I think you're hitting on the fact that there's a low barrier to entry to do that for patients. To some extent, there's a low barrier to entry without higher level governance to doing some of those things that you'd mentioned that you're uncertain, like how are providers using this in their day-to-day work. And I know in my day-to-day work, yes, I work in IT, but still in my day-to-day work, I use LLMs pretty regularly. Sometimes I use other generative AI. And so what I'd be interested in is kind of looking at the patient first. To your question, like, what do you have a kind of a working hypothesis, or do you have a place you tell people to go as providers to say, here's where you can get, like you just mentioned, the CHAI, that website. Where would you suggest people start to understand, like how to use it effectively for healthcare? How to advise patients to use it effectively, and what they ought to share to their providers. So when I come in and I've visited Dr. Google, you can probably tell from some of the things that I've done. But is there the same kind of either tell, or should I be informing my doctor, hey, I put these things into Chat GPT, and here's what it said, and this is what I'm concerned about, and why I'm thinking that maybe you need to consider this kind of intervention or treatment for me. So, what are your thoughts on kind of guidelines around that?
Yeah, I would approaching this practically. I think it's important for the hospital systems, the contract groups, employers, to do that work and help the the individuals, on the ground level, because right now, everyone is just overwhelmed. If I give them one more assignment, hey, go out there and do your own research on ethics and teach yourself about the dangers of LLMs and the potential benefits. And I want you to read up on this. They can go to the HALM textbook. I wrote chapter 29 on ethics. They can start there. But it's a lot. Right now I can't even get everyone to do all their CMEs or flu shots on time. If I give them some, assignment on medical ethics, it's I know what the reaction will be. So I think as the health system, as the chief medical officer, I have to get together with the other clinical leaders and with the IT department and with we have ethics committees and with legal, and say, hey, how are we going to stay abreast of this? What are we going to advise? How much can we really control? Can't tell the patients not to use some application or some device. Can we really even monitor that for the physicians and the APPs and the other clinicians? Or do we just provide a resource and guidance? So I did run across this multi-scale ethics framework in one of the organizations, and it's actually tiered. So for the individual, who benefits or loses, and there's considerations for rights, privacy, fairness. But then, we move up to the groups and the communities, they take on a little bit more responsibility. Then we go up to systems and institutions, and they should develop some sort of infrastructure. Do they, have different fits for their organizations, levels of control, and also looking at access, fairness, privacy. Then go to nation society, and that's certainly above my pay grade. And then the globe. So I'm not sure who would be in charge of this, but how does this affect the planet? How does it affect geopolitics? So I think the place for people probably listening to this podcast is on the group, community, and system level, to go out and survey and ask and say, hey, how are you guys all using this? What are your concerns? Have you thought about this? One thing we haven't really talked about in many communities, certainly in the hospital I work at, we're the second largest employer in the county. I think a lot of hospitals, healthcare institutions are large employers in their communities. And will AI result in a major reduction in the workforce? The back office personnel, some of the entry level folks. Will we have, I don't know, autonomous systems, robots doing things in the next couple of years? And will that have, we've talked about patients, we've talked about providers, we haven't talked about the other people who work in the hospital. It's a big employer, right? 20+% of the US economy. Are we going to displace all those people? Do we have some responsibility to them as well? So that's something I haven't heard quite discussed yet. That also might not need to enter into the governance conversation. If we, we want to always save costs in healthcare. We want to be, we want to avoid redundancy. We want to avoid waste. We want to be very efficient. We want to be accountable. And the people who pay the bills, CMS, the insurers, the patients through their co-pays and deductibles, want us to be efficient. But what does that mean when it has a real human cost? We've seen our workforce increase. We might be at the point where it begins to decrease. And how's that going to affect the community? Because that's certainly going to affect the health of the community if people suddenly find themselves without a means of income. I know I've heard conversations on a larger, societal scale about a basic income. Again, way above my pay grade. But what do we owe to the people that have been working alongside us for 10, 15 years? Do we start to retrain them? Do we teach them? Do we adopt methods to enhance what they do? I don't think we started to talk about that yet either.
So Dr. Olszyk, not to put you on the spot here, but I'm going to. what positions, and you hear different things. I think it'll depend on which hospital or facility you talk to, because you also hear cases where they're critically understaffed and could use some of these tools. But um, I can also see the flip side of the coin. So what positions within a hospital or health system do you think would be most at risk of um, being replaced by artificial intelligence in the near future, the next 5 years or so?
This is pure speculation, but I think a lot of the back office folks, I'm thinking about schedulers, billers, coders, the people who go through the electronic medical record, look for certain diagnoses, codes, maybe interact with the insurance company. I know that, there's always a little bit of a back and forth. We'll get some denials, and then one of our advisors will engage in a face-to-face. I know that some of the insurers are using their own AI models, and we're probably going to deploy ours, and it's going to be, robot wars. But it's going to move so fast back and forth that, I don't know that, somebody sitting and I'm thinking of people sitting in cubicles right now doing very good work, meticulous work that I can't imagine doing. I wouldn't know how to do it. But I do think, if there's this, algorithmic spiral, they might get, caught on the outside of it. I mean, think about banking. When I remember, when I was a kid, we used to drive to the bank and my dad would deposit a check with a teller, and if you wanted something, well, in the interest of efficiency, we got ATMs, and now we're probably going to move beyond cash very soon. That displaced some people. So that's natural, but I think we're seeing the potential to have it on a much larger scale than we've ever encountered before. It's going to move so fast that it's going to be hard to catch up.
Even if some of the staff are replaced, there will always be a head to chop somewhere, and that person will the person responsible for the submission of all the data, whether it was generated by people or by AI. So in that regard, do you find some of the leadership positions are going to be um, really just taking a look over all of the AI generated data for any inaccuracies or mistakes and then submitting it? Do you think we get to that level, or will there always be a need for a team of folks to be um, taking a look at the data and making sure it's accurate before submission? And I'm thinking along the lines of revenue cycle management, right? You got to make sure that the dollars are coming in the door, um, and keeping the hospital afloat. So, I think that there are some great applications for AI, but I don't know that I'd be willing to unleash it on the entire revenue cycle operation and just yet. But Mike, what are your thoughts?
Well, so I guess I'll offer a quick thought here, and then I'd love to discuss it a little bit. One of the things that I've been exploring in my own kind of interest in AI generally is like when it comes to generative AI, because it's designed to operate in a non-probabilistic manner, or in a probabilistic manner, excuse me, I should say. It's not a non-deterministic manner, meaning that, I'm sorry, I'm using dumb terms. I should just say it's got a bunch of probabilities that it uses to determine how to respond, and it does not have an innate model of the world or of the domains that it's working in. It just has a probabilistic set of probabilities. It looks like it knows what it's saying, but it doesn't, which is why it sometimes says things that are crazy from our perspective and that we would call hallucinations, or at least that look real but aren't real when you look under the hood. So where they cite studies that don't exist, and they cite laws that have been passed that don't exist, and provide actual details like, here, you can look it up here, but when you look it up, that's not what it is at all. That, to me, I'm coming to believe, is innate to to generative AI, that it is not something that we can limit it and we can reduce it, but we can't completely remove it and still get the generative aspect that we're looking for. And with that in mind, my personal belief, so I'll just say that out loud, is that we'll never get to the point where you can fully remove the human in the loop. We may eventually decide that we can encode that human in the loop in another controlling, like something that orchestrates and checks, that is more deterministic. But that will be designed by a human, and ultimately that human or set of humans will still have accountability for how that behaves and how well it does at ensuring that the generative aspect of this doesn't result in, a dangerous hallucination or outcome. And so in that sense, the same way you have pilots who, fly the plane for us while most of the flight is actually being done automatically. I think in healthcare, you're going to continue to have highly educated people who understand where the risks are and what needs to be done. That may change what a provider's role looks like over time. And I'm not going to talk about time horizon for that to happen, because there's a lot to be done still. We're at the early stages of this. Might go really fast, as some people feel. It might take longer. We might be coming to the end of what generative AI on its own can do. And I'm not intelligent or educated enough, I guess I'll say, on some of those things to make a guess. But regardless, as long as we're using generative AI, I personally believe you'll have to keep a human in the loop, or you'll have to keep a governor of some sort that's more deterministic and has been designed for that in the loop. I don't know. Dr. Olszyk, thought?
I don't know. I guess I agree with everything you said. I'd like to stay in the loop as much as possible. I think it's be very non-controversial to say that health leaders going forward will need to have more understanding of. IT sounds like a very, very broad category, but to understand more and more how these algorithms, models, applications are embedded in our workflows. So, healthcare leader now has to understand, as you said, revenue cycle, has to understand HR, has to understand marketing and raising donations and medical standards and equipment. It's a very complex job that has to be done right. It's expected to be done right every single time, every single day. A lot of times we compare healthcare to the airlines. So we want to be like the airlines and have the safety record. Well, you can ground a plane, if it's bad weather or if you're missing a part. We never shut down the hospital. We're open 24/7, and we take everybody. We turn nobody away. That's not just the law. That's our mission. And every 2 weeks in orientation, I say, we're unlike any other vocation or job or industry. We take people, whether they can communicate or not, whether they're conscious or not, no matter if they want to be here, take care of them because they need to be here, regardless of ability to pay or to be courteous or even participate in the examination. So we serve everybody, and hopefully we model it so that we treat everybody justly and fairly with the utmost safety and quality. This is just one more consideration to fold in. It's an increasingly prevalent and important one, and it's going to have a lot of ramifications, and it's going to inform everything. It's going to touch everything that we do. So someone who's going to be a leader either needs that background, or is going to have to devote a lot of time and attention to understanding it.
So, Dr. Olszyk, you wrote the Chief Medical Officer's Essential Guidebook. We've been talking about ethics. What are some nuggets in your book that you can share with our audience who don't have a copy yet? And we'll put some information down below on where they can find a copy of the book themselves.
Yeah, I appreciate that. The book came out. It's going to be almost, believe it or not, 3 years since it came out. So I guess we'll have to do a second edition and have a whole section on IT and AI and all the considerations. But I wrote the book kind of in response to a colleague who also became a chief medical officer, and somewhere along the way, I must have shared some tips, and he remembered it as a top 10 list. And he asked for it a few months later, and I actually forgot I shared the information with him. But it gave me the idea that there's probably something in my experience and the experience of other folks who have had similar positions to share, because it's not an easy job. It can be a very lonely job. You're building the bridge between the administration and the medical staff, and you're often faced with dilemmas. Which side should you consider? Who do you listen to? And so you really need a true north. And the book is divided into sections. I think my inspiration was like the classical or medieval model of the body. So first we start off with what I call the bones and the sinews of the chief medical officer, and then it's the heart, it's the relationships, it's the brain. So it's dealing with finance and strategic planning, and finally we get into what does it all mean? So the transcendence. So in that section we cover ethics. And meaning and justice, and you're often faced with questions that don't have easy answers. So you need to ground yourself in an understanding of what it means to do right by people. So we go back to the various ethical norms, or the principlism of Beauchamp and Childress, or even other traditions. Not everyone really accepts principlism. They find it lacking in some regards. So I think the book will help other chief medical officers or people who are considering it or work with them to understand what the job really entails. And there's a lot of stories that are shared. It's not just other CMOs, it's people who work with them, board members, medical staff leaders, administrators, etc. And it was written kind of, here's some mistakes I made along the way, learn from mine so you don't have to repeat them. But I've gotten a lot of good feedback, so thanks for asking. And based on our conversation today, it's certainly time to update it and bring in what's topical that we've been discussing at some length today.
Well, Dr. Olszyk, thank you for sharing the perspective of a chief medical officer on this topic today. This concludes another episode of the Next Orbit podcast. We'll see you on the next one.
The Next Orbit podcast requires more than a conversation. Be sure to subscribe, write a review, and share it with someone you think would benefit. Thanks for listening, and we'll see you on the next episode.